Good evening, everyone. On behalf of Intouch Pharmaceutical Limited and Janet Division, I, Dr. Mithilesh Nayak, welcome you all to this 8th episode of Endocrine Talk Show. And today we are going to learn about the various clinical aspects in the management of thyroid disorder. And to guide us to moderate today's session, we are having with us our guiding force for this webinar series, Dr. Subhankar Chaudhary sir. He is currently a professor and head department of endocrinology as SSKM Hospital, Kolkata. And he's going to give us an overview of this program and then he's going to moderate this session. So with this word, I hand over the session to Chaudhary sir and request him to introduce our panelists for the today's program. Over to you, sir.
Thank you very much, Dr. Mithilesh. It's been a wonderful collaborating with your division in INTAS over the last 2.5 years, conducting various sorts of educational programs for physicians with endocrinology in mind. And I have found, at least from the data that your team has shared, that there is a high level of interest that's been shown by the physician community in being with us with this program month after month. So thanks for your organizational strength, and thanks to all our panelists who have been with us over these more than 2 years to make this program interesting and informative. This evening, we shall talk about thyroid. So this is Tales of Thyroid, and there are many tales that thyroid can provide us with. And to take us this evening, we have very renowned people from across the country, endocrinologists whom everyone knows by name. So I'll just briefly introduce them. Maybe I have on my screen Professor Sushil Gupta, who is Professor, Department of Endocrinology at the SCPGI at Lucknow. And he is, of course, very committed to bone mineral metabolism, and he's also appropriately Vice President of the Indian Society for Bone Mineral Research. And we also have with us Dr. S. Madhukar, have you joined? Maybe Dr. Madhukar Rai is also supposed to join, who is Professor and Head Department of Medicine at Institute of Medical Sciences at BHU, Varanasi. Though he's in the Department of Medicine, he's very much an endocrinologist, and he has been an invited speaker at various national fora. He had also been treasurer of the Endocrine Society at one time. We have another very senior person joining in, who is joined from Jaipur, Dr. S.K. Sharma, a longtime friend. He is a senior consultant endocrinologist and diabetology at Galaxy Specialty Center in Jaipur. And he is, of course, the name should be enough to introduce him. And we also have a representation of the younger generation, showing the immense promise that we see in the future of endocrinology in our country. And we have two of their representatives. One is Dr. Abhay Sahu, who is, of course, in that sense, maybe younger to us, but is very senior endocrinologist. He's a professor in the Department of Endocrinology at IMS and some hospital in Bhubaneswar. And he is a wonderful speaker, great person, great organizer. He was organizing secretary of the highly successful ESICON in 2018. And we also have Dr. Mohan Shenoy, who is consultant endocrinologist at the Sri Gokulam Medical College in Trivandrum. He has had various accolades, won various awards, medals. And at this point of time, I think he is doing a wonderful job putting up the Endocrine Society of India on the social media. Thank you, Mohan, for all your efforts. So we straight away go into the tales of thyroid. And Madhukarji has joined. Good, great. Thank you. Good evening, Madhukar Rai.
Good evening.
Good evening. So I said we start maybe with some tales of thyroid. Maybe I will start with a story, small story, make it short. And I have taken note of the fact that Dr. S.K. Sharma and Dr. Abhay Sahu would like to be left as soon as possible. They have other important social commitments, I'm sure. So we will try and do that if the other panelists agree. Otherwise, we won't leave them till the end.
Please.
So I do remember still of let's say 55-year-old lady who was referred to us to me almost 10 years, more than 10 years back, by a surgeon. She had undergone a lap cholecystectomy, following which she had port site infection, and she was eventually being put on anti-tubercular treatment. And she was a known hypothyroid, and her TSH was in the 30s. So she was on probably about 100 micrograms. So I increased that to 125, and I went on increasing. And every time after 3 months or 4 months, she would come, the TSH would remain around the same. And if you look at the free T4, that was always on the lower side. And every time I would ask her, are you taking your medicine regularly? And she would say, yeah, of course, I take the drugs regularly. And I went on increasing the dose. And this is the only instance that I can remember that I have put someone on, and she's also, not very young of age, 55 years. I'd gone up to 500 micrograms of thyroxine per day. I've never done that before or after, ever. And the TSH is, at one time, maybe it had come down maybe to 15, 18, 20. And then once she was accompanied quite often by her daughter-in-law. And then once I said, can you kindly take over the responsibility of making sure that she takes the medicine regularly? So she said she works in the morning, she has to leave home early. There could be some uncertainty. So I said, what about giving a cumulative dose every Sunday when she's at home? So whatever approximate dose she would need every day, multiply by 7, maybe reduce a little bit. And I said, give this, and please make sure that you administer it every day in the morning. And then the next time she came, the first time in the course of maybe 1.5 years, her TSH was 5-ish or something. So I realized that, we all know compliance is such an important issue, and patients will have so many different reasons, but this was a particularly resistant individual who every time would say, yes, I'm taking, but I was sure that she wasn't taking it. So, but that went on for some time. And then again, she came back maybe after another 1.5 years, when the TSH was back to 35. And I said, what happened now? So, and then this time she wasn't accompanied by her daughter-in-law. And I learned that the daughter-in-law was now pregnant. And so I put 2 and 2 together and thought maybe she now had other priorities in her life, and maybe now she's also forgetting to give her the medicine. And so this is only as an opener, trying to emphasize that blood reports are important, labs are important, but it's so very important to communicate with the patient properly. And I must admit that I failed to get the right information for maybe 1.5 years. So this is a learning point that I thought I can share with all of you. And would Dr. S.K. Sharma bring us some folk tales from Rajasthan related to thyroid?
Well, thyroid disorders are very, very common in our part of India. And thanks to one of the professor of medicine in our very famous medical college, the criteria for diagnosing hypothyroidism was that anybody who is obese was given thyroxine. And then when we landed after DM, then the company people, at that time only Altroxin was available. So when we landed, the company people started complaining that since you are here for the last 6 months, the sale of Altroxin has gone down drastically, because she was looking at weight and just increasing or decreasing the doses of thyroid preparation. So some of our patients were taking 5, 7, 10 tablets per day. So once we started educating our physician friends that the dose of L-thyroxine sodium is 1.6 microgram per kilogram of body weight. You have to give it empty stomach, wait for 45 to 1 hour, and then don't give it with any other drugs like antacids or this PPI and iron preparations, etc., or calcium. Then people have now started realizing that 1.65 microgram per kilogram body weight is a sufficient dose, and now most of the patients are receiving like you can say 75 or 100 microgram, and they are very good control. So it is definitely the pattern is that every obese patients are considered to be hypothyroid, but that is not the real picture. So obesity is rarely seen in our hypothyroid patient, and we should do not commit that obese patients are hypothyroid until we investigate and look at TSH and T4. Thank you.
Thank you. That was a great message, and I would appeal to all our participants, our audience across the country, to kindly put in your questions so that we can deliver it to our esteemed panelists. So I'm still waiting for something. And to continue the chat, can I ask Madhukarji, because Banaras is known for pan, apart from many other things. So only very recently, one of our younger colleagues, he came up with a patient who once again had difficult to control TSH, and he was sort of a chain pan taker, was taking 15-20 pans every day along with the tune that we use, tuna. Yeah. And then he said that I asked him to stop his pan intake along with tuna intake for at least 6 weeks or so, and come back to me with repeat thyroid tests. And lo and behold, the results had come out as normal. So, Dr. Madhukara, do you ever face such challenges in your part of the world?
Actually, in our part of the world, people are consuming pan, but it's very unusual for somebody to get up in the morning and I'm just wondering whether this was he was hypothyroid on account of that pan.
No. Just the dosage, despite adequate dose,
okay,
the TSH was not controlled. That was the question. I mean,
so usually we don't find this type of thing because a lot of people they take pan, and one message I would like to communicate here is the patient should be told very clearly that this is not a drug. Most of the time they believe that this is a drug and it is to improve their thyroid. It should be very explicitly told to them that this is a replacement and your body is deficient of that. So most of the time what they do is, the moment their TSH drops to normal, the drug is stopped by themselves or their treating physician. So it should be very clearly said that adequacy of TSH is nothing but adequacy of the dose which you are taking. And unless there is some other reason, please don't stop it. So that's one message, because patients mostly think that this is a drug. And this is not a drug. This is
absolutely
just a replacement.
Very important message.
Absolutely.
Yeah.
Very important. Because many a time patients would come to me and say, Doctor, shall I continue? Because the TSH has already come down from 100 to now 1. So if I continue, then it becomes 0. So that's a very important message.
And another thing is that when we discuss as an endocrinologist that a patient who is taking adequate drug of adequate dose of L-Troxin or thyroxine, whatever it is, and he is not getting controlled on 200, 300, 400 micrograms, we start thinking of something else. So that's a very, very rare situation, and that one has to look into. I don't know. I had a question that what is going to happen for those patients who are developing malabsorption or those who are undergoing bariatric surgery?
Sir, I want to share the same thing what you were telling. Sir, first you finish your thing, then we'll discuss. I want to share one important thing.
So that's one thing one has to think of, and very rarely we find some of the patient whose requirement is very high, and we usually, even if looking at the compliance and everything, sometimes admitted the patient and gave them the medicine. Still, so that is one possibility, but it is between the endocrinologists. This is like once or twice in your lifetime you'll see such a patient who is requiring 300, 400 micrograms. Otherwise, most of the time it is a compliance, and the belief by the physician that the moment TSH is normal, just stop it. That should be
right. Absolutely. So, Abhay, maybe you quickly share, because we have some questions in the chat box, then we can address them as well. But please.
1 year back, actually, one 14-year-old child came to us purely hypothyroid, primary hypothyroidism. We started replacement and gradually we increased the dose up to 250 microgram, normal body weight. So then I told her mother that you start giving a supervised dose. Her mother used to give, and with 250 the TSH was normal. But recently, only 3-4 months back, then we found out her hemoglobin was 9.5. Then again, we just no GI symptoms, nothing. We just by curiosity we did a TTG antibody, it came positive. Then we sent her to our gastroenterologist. They did a biopsy. Then it was a biopsy proven celiac disease. Then we started giving gluten-free diet. Now with 100 microgram, our TSH is normal. So that is also one of the important things. If people who are requiring very high dose, probably one should keep in mind these are there are certain also malabsorption syndrome also plays a critical role in some patients.
Yeah, and may not have overt gastrointestinal symptoms is the other important message we wanted to give. Yes, Dr. Sushil, can we go on to answer Dr. Harsh Mittal? How often should TSH and free T4 be checked in type 1 diabetic children? Before you share any of your own tales.
Thanks, Dr. Shubhankar. The basically type 1 diabetes autoimmune disorders and the chances of type 1 autoimmune thyroiditis is pretty common in this, up to 8 to 10% of children actually. So at the onset and every year or every 1.5 years, they should be screened for TSH. That's very important because that's one of the common endocrine autoimmune disorder associated with this. As Dr. Abhay Sahu said, celiac disease is pretty common in these kind of people. So these are the autoimmune disorders commonly screened for in type 1 diabetes actually.
Right. Yeah. Okay. Thanks. And Mohan, would you like to share any particular story that physicians can learn from?
Yes, sir. So this is a story from when I was in my training period, 2014 period. That is, I was in Amrita at that time. So this lady, about the 45-year-old lady, comes to us with clinically thought of Graves' disease. She has tremors, palpitations, all those symptoms we associate with, and her eye was actually a bit bulged. So we thought, because she's thin built, so investigations were on with the Dr. Jayakumar sir's patient. So Professor RVJ sir suggested us to go through full history. So we worked her up for we didn't much of a uptake on the scan. So we went for the other test as well. So the TSH was very much suppressed, T3 was elevated, but we don't get much other values. So I think about 1 year time, we gave low dose of antithyroid drug. And despite that, the values were not getting stable. And see, we thought of going for ablation as well. At that particular point of time, her husband came to us and told that there are some other issues which are there. And it was found out that the thyroglobulin level was also checked meanwhile. And it was a case of factitious hyperthyroidism, factitious thyrotoxicosis. So we just got mimicked. So there was some dispute in her family and all. So for getting attention of them and all, they wanted to defer that settlement. So she was buying time by giving this medicine herself. And it was in a herbal preparation. It was not the usual thyroxine, we know that. So I think RBJ sir really congratulated all of residents because we took careful history. We actually asked the parents, her family to go out and check her belongings sometime. Sisters were also there. So it was very, very like a vigilance department. So we had to pay vigilance with that. And after that, I saw one publication published called Thyrovigilance by Dr. Sanjay Kalra sir. So the same mention was there. Whatever we feel in the clinical history may not be there. Sometimes we should think of some other causes like factitious hyperthyroidism, and that was the case. So that was very easy to diagnose, but I think thyroglobulin was checked, and that was enough for us to get answer. Thank you.
Excellent. Thank you. So we already have quite a few more questions in the chat box. So once again, it's Dr. Mittal. So who will take it? Maybe Dr. Sharma, will you take it?
Yeah, please.
Do women with mild thyroid function test abnormalities pre-conception or during pregnancy benefit from thyroxine treatment?
Yeah, the hypothyroidism or hyperthyroidism during or just before pregnancy, it's a very common scenario in our practice, and we see large number of these patients referred to us by gynecologists either for the IVF, etc., or once they are pregnant and their values are abnormal, then they are referred to us. First important thing which I want to highlight in our colleagues who are joined today is that in pregnancy there is a increase in TBG, that is thyroxine binding globulin, and because of that the total T4 is high, and this is a physiological rise in T4, and TSH will be slightly depressed because of physiological changes. So looking into that scenario, never jump to considering that the patient is having hyperthyroidism. You have to look at the neck of the patient, you have to look at the history, and then of course antibodies like TSH receptor antibodies are helpful. These are some of the tests, or now we can go for ultrasound and look at the Doppler of thyroid and see whether the vascularity is high or so. But very important point here is that not to jump to anti-thyroid drug during the pregnancy because of increase in TBG and increase in total T4, and there may be some decrease in TSH in this type of patient. So you should refer this patient to endocrinologist if you have any problem there. Thank you.
Yeah, but what about treatment with thyroxine, maybe with mildly elevated TSH?
Yeah, that is
maybe
very
two situations. One is a lady who is planning to get pregnant, another one who is already pregnant.
Yeah.
So what would be the TSH cutoffs where you would start treatment?
Well, the subclinical hypothyroidism, what we say is that if the patient is having more than the reference value of 4 and it is less than usually 10 and T3, T4 are normal, then we say it is subclinical hypothyroidism. Before pregnancy, of course, there are studies. If the patient is having TPO antibody positivity, then probably we should treat them. If the patient is undergoing some artificial reproductive technique help, then of course we have to give let's say small dose of L-thyroxine sodium like 50 microgram, because it is argued that this small dose is not going to cause any harm to the fetus and to the mother. Once the patient is pregnant and having this subclinical type of presentation, of course, if it is more than 4 and it is TPO antibody positive, we usually give these patients thyroid supplementation. It may be again a small dose of 50 microgram or so. And once the patient delivers, we can again re-investigate the patient whether she is continuing to have hypothyroidism, or we stop the drug and recheck after 1.5 months of stopping the L-thyroxine sodium, because the half-life of L-thyroxine sodium is long. So we have to give long duration. So 1.5 months, and then we recheck TSH and T4, and then accordingly identify whether the patient is having permanent hypothyroidism or it was some abbreviations during pregnancy. Thank you.
Right. So this
can
is one area. Yes.
Can I?
Yes, Madhukarji. Yeah.
I would like to differ a little bit because if the patient has got, especially I have seen like more than a dozen patients who had difficulty in conceiving, and TSH was around 8, they were not anti-TPO positive. So one is that one should look into if it is asymptomatic and you are getting anovulation, probably in order to conceive, you have to start the treatment. That's one message. I would like to communicate. Sometimes a subclinical hypothyroidism could itself be responsible not for the florid symptom, but for the very nicely poised hypothalamo-ovarian axis. So that needs to be treated. And
sorry, yeah, go ahead.
Anyway, that's what I wanted to say. That many times,
yeah, absolutely.
And secondly, if for any lady who is planning to conceive and she has got a TSH which is high, I usually order an anti-TPO because of the studies which show that even if there is a subclinical hypothyroid or the patient is anti-TPO positive, and very little subtle elevation in TSH could lead to abnormal fetal outcomes. So that is one thing I would also like to do.
Yeah, definitely. This is one situation where our threshold for starting on thyroxine is relatively low. But as Dr. Sharma also pointed out, I often also tend to reevaluate after a successful pregnancy is over and decide on committing to long-term treatment. So we do see hypothyroidism in different phases of life, and one was in relation to the reproductive age group women. The other could be at birth, and then the other issue could be in the elderly. So can we quickly go through these different phases? Maybe first, Dr. Abhay Sahu. So how should we diagnose congenital hypothyroidism and how should we manage? Quick word of advice. We already have quite a few questions in our chat box, so we can come back to them gradually.
Yeah, sir, once we are telling congenital hypothyroidism, usually after birth, clinically, we can tell these are good babies. That means they will always sleeping. They are not crying for any food. And they, majority time, they have actually just lethargic-like things. And once you examine, probably they have a umbilical hernia. There will be macroglossia. There will be wide enlarged fontanelles. Of course, you can see that is the pore spaces and the skin will be dry. And of course, sometimes you might get prolongation of the physiological jaundice. So these are the certain things which actually makes clinically that patient might have congenital hypothyroidism. Besides to tell, now actually there is universal screening for TSH. So whether you get the symptoms or not, probably after every child getting childbirth in the hospital, we are doing a HILPAD prick and we are doing a TSH. And that TSH actually help us to guide us whether the patient is hypothyroid or not, whether the person requires treatment or not. Usually, if we are doing, normally we usually advise at 72 hours, but sometimes people do in the cord blood or sometimes the HILPAD in the first 24 hours. So that again, that is a little bit controversial. What will be the level of TSH where you should decide that you should start treatment. There are actually few guidelines. If it is actually more than 40 in first 24 hours, it is no need to think you start treatment immediately. But if it is between 20 to 40, probably you repeat another TSH after 2 to 3 days, probably by 72 hours. And usually by 72 hours, if TSH is more than 20, again, probably you have to start treatment. But again, the gray area is between 10 to 20, because this is the phase where actually, again, it is very difficult to take a decision. Less than 10 is normal. There is no need of starting treatment for those people. But those who are having between 10 to 20, TSH of 10 to 20 microinterferon per ml, in those cases, you can repeat another TSH at 4 weeks. And if it found to be more than 10 like that, then again you should start treatment even if in those groups. But for everybody's information, usually TSH comes to the adult level by 3rd month, not that before that. So we have to actually keep in this mind. These are the certain values which actually guide us to particularly management of congenital hypothyroidism.
Yeah, so these days we need to try and go for as thorough neonatal screening as possible. Of course, we do not yet have it as part of the universal screening in GovMed setup, but we should try and implement that wherever possible.
But it's a hospital setup we are doing in every patient.
Yeah. And then we come to the other end of the spectrum in the elderly. And Professor Sushil Gupta, what should be the special care that the physician needs to take while managing hypothyroidism in the elderly?
It's a very, very interesting and clinically important thing actually, because hypothyroidism in elderly is very subtle. The features are very subtle actually. They present with just weakness, lethargy, sleepiness, constipation. So therefore, in elderly people, they should be screened for hypothyroidism if these kind of symptoms are present. If you look at the prevalence, it's pretty high actually. It's around 15 to 20% up to the age of 65 years, more in the females. So the diagnostic criteria remains the same, except one thing is to be kept in mind, that there is a progress. Even in normal elderly people, there is a progressive rise in TSH. By the age of 80 years, the upper limit of normal of TSH around 7.5 actually. So finding a TSH of 6 or 5 in a person who is around 70 or 80 years of age can be regarded as a normal. And these are normative data of TSH for elderly people in population actually. So one has to take care of upper limit of normal. The normal TSH of 4.5 or 2.5, which is applicable to young people, is not applicable to elderly people. Second issue is, when you're starting the treatment, one has to rule out coronary artery disease in these people, because it could be like subclinical, and starting levothyroxine is maybe detrimental. It can precipitate the angina or myocardial infarction.
So to what extent should we investigate? Do we need to do a coronary angiogram before starting?
No, not at all. Not at all. Not for coronary angiography. The best thing is to get look at the symptoms. If they would have shortness of breath or chest pain or an exertion, one should. This is a high target population for going for extensive cardiac evaluation, but not angiography certainly. One should get an ECG done and echo done, and start the smaller dose of levothyroxine, say around 12.5 micrograms daily for about 1 to 2 weeks time, and gradually escalate the dose by 12.5 fractions every second to third week actually, and build up the dose to bring down the TSH levels back to the normal level. Normally in these people, the TSH level is kept as a high normal, say around 4.5 or 5. And because over-treatment in these people can lead to the atrial fibrillation and other cardiac events and osteoporosis on a long-term basis. So they should be finely tuned on an upper high limit of normal range of TSH for that age group, like 5.5 or 6 as the age, decade-wise age, this thing. The most important thing is that high TSH in the age group around 80 years of age is more of a protective phenomenon, probably actually. So that's a strong possibility we think of in these days. So it's not difficult to treat these elderly hypothyroid people, but the only thing is, one has to keep a track of CAD, atrial fibrillation, osteoporosis. Over treatment is really dangerous in these people. Better to under treat a little bit rather than over treat these people. Yeah.
Right. So the mantra here, as Dr. Gupta said, is not be overzealous in this elderly population. Thank you. So, Mohan, maybe you tell us, maybe let our physician audience know what could be the monosymptomatic presentation of hypothyroidism, because everyone may not come with the full entire spectrum of symptoms. So which would be the conditions where they would suspect and do a test and then therefore treat those individuals?
Thank you, sir. So there are some conditions where we just get patients coming with very simple symptoms, but they don't have the accurate value. So such a case is a weight gain and menorrhagia. So when a person comes with weight gain, there are some situations where think it is thyroid, but it is a monosymptomatic thing. But when you have some other symptoms, we just feel, but that is one condition, weight gain. Then menorrhagia is one condition, because in puberty menorrhagia or in the middle age, we have some conditions where descriptions of monosymptomatic presentations of coming with hypothyroidism. For that, when we correct the thyroid, the bleeding also stops. Similarly, in infertility patients who are undergoing treatment for planning for infertility and or fertility, so or that period also, when we want a value which is better, so when we correct the thyroid functions, that time it actually it improves and they try to get fertile. Then galactorrhea is one condition where hypothyroidism, uncorrected hypothyroidism can lead to prolactin level elevation, and that itself can be leading to galactorrhea. So that is one condition. Then recurrent miscarriages. So when we investigate some conditions where we have got anti-TPO positive, but we don't know what it is. So monosymptomatic presentations of hypothyroid may be seen with this as well. So too with polycystic or multicystic ovaries. Then I think so many conditions are there, like the pericardial effusion. When we diagnose with pericardial effusion, sometimes there will be uncorrected hypothyroidism, sinus bradycardia, when a person is active, still not getting refractory anemia, because anemia is one condition which we have, but when we are so that thyroid also is abnormal, that also can see. So hypothyroidism in adults present with so many condition, dyslipidemia, because recently we had a subclinical hypothyroidism with dyslipidemia, so that also can be one of the misnomers. Then carpal tunnel syndrome. In neurology, we have some conditions where carpal tunnel syndrome can be diagnosed like that. Dementia. So there is another area of interest where a person forgets. So reversible cause of dementia is on a hypothyroidism. Then at last you got a depression. There's also one more condition. So besides that, there are so many conditions like constipation, gastroenterologist diagnose. But I think as a physician, we should not jump into diagnosing hypothyroid just by base of symptoms. We should give them a follow-up. At 6 weeks follow-up, we have definitely persisting values. Definitely we should treat correctly. And whenever we have a doubt, always refer to endocrinologist.
Thank you. Thank you. Yes, Dr. Sharma.
Yeah. Another important scenario is short stature or failure to grow in our young people. That is again a monosymptomatic, and a poor scholastic, you can say school performance is another a pointer where we have to investigate. That is another important point.
I was focusing on adults. Yes, sir.
Absolutely. Yes. Yeah, Mohan was focusing on adults only, but about the poor scholastic performance, I think we need to be a bit careful, because even if found to be hypothyroid, if you treat with thyroxine, I think we cannot guarantee that the scholastic performance improves. In fact, sometimes it may deteriorate, maybe because he or she was a relatively quiet sort of boy or girl in class, following teacher's advice.
Sir, some people have shown increased scholastic performance with hypothyroid during the phase of hypothyroidism, because they always keep inside the room and they actually helps them to read. And it has been found that those people having poor scholastic performance after thyroid replacement, their actually activity increased so much again that scholastic performance remains that much poor. So usually,
so that we have to be careful, but this may be another setting where you can detect hypothyroidism. So we have many questions in the chat box. So let's have Dr. S.K. Sharma once again. Dr. Mundal wants to know whether you feel that thyroid disorders have increased after COVID-19 had come. Very relevant, pertinent question.
Well, not really very increased, because there are some reports that thyroid is also involved in the COVID infection, and it may lead to some thyroiditis type of picture. But it is not like this that we see large number of thyroid disorders now. But there are some case reports that thyroiditis is increasing because of COVID. Thank you.
Right. So would there be any other comments on this? I also personally don't feel that I have seen a whole lot of thyroiditis cases, but there have been some. Sushil,
actually, if you look at overall incidence of thyroid disorder in COVID infection and vaccination, there are two stages actually. COVID infection can cause subacute thyroiditis, painless thyroiditis, aggravation of autoimmunity. But at the same time, vaccination is known to precipitate various autoimmune thyroid disorders, actually, which we call as Asia syndrome. The only thing is, it is not enormous proportion, but one should suspect actually if it is following vaccination, you've got a thyroid disorder, autoimmune thyroid disorder, say by almost within 2 months of vaccination, then one should suspect Asia syndrome. We had about 10 or 15 cases of Asia syndrome, presenting with all the variants like Graves' disease, Graves' neuropathy. We had subacute thyroiditis, we had painless thyroiditis. So whole spectrum was there. Now, very recently, we have also observed that there's a transient elevation in the thyroid receptor antibodies in some people with subclinical thyrotoxicosis actually. So this is a very recent thing which happening, but this could be, but we are observing more often actually than earlier. So there is a link, certainly yes, but it's a large, not a large numbers. It's not a large numbers. That's true.
Thank you. So we go on to more questions in the chat box, and Dr. Kothari. So will Dr. Madhukar Rai take this question? Any preventive role of steroid treatment in hyperthyroidism? If yes, when and how we can use it?
Preventive role?
Yeah, that's the question. That's an autoimmune disorder. So
I think
with steroid and suppress the autoimmunity.
We give steroid, especially in thyrotoxic crisis. Definitely, if the thyroid, that's an entirely different thing. But to my knowledge, it is because, except for Graves' or ophthalmopathy, where sometimes we are using steroid, or in cases with severe thyrotoxicosis or a patient with thyrotoxic crisis. Otherwise, I don't think there is a role of giving steroids.
Right. Yeah. And of course, we.
So even if in severe thyrotoxicosis, there is no role of any steroid. Probably in thyrotoxicosis,
thyroid storm,
thyroid crisis, then orbitopathy, then topical steroid in then dermopathy. These are the three probably indications where actually thyroid toxicosis to the steroid comes to the role. And even if severe thyrotoxicosis without thyroid storm, also they don't require or warrants the use of any steroid.
Usually, it takes care of that the period when we are the thyroid hormone is being secreted so much. That my experience is that if you give a short-term steroid, it definitely improves, especially patients who are very elderly and they are having a lot of thyrotoxic symptoms and almost heading towards crisis. That helps. I have used few of the patients, although this type of scenario is not very common, but not for prophylaxis and prevention. Definitely not.
Right.
So can I add
to say something?
If you enlarge the scope, if you enlarge the scope of this question to immunosuppression, actually, so are we thinking of immunosuppression for Graves' disease because it's an autoimmune disease? There are recent reports that immunosuppression with rituximab has been used in some studies in Graves' disease in young people actually. Not a huge experience with us also, but not many reports are either there. There are a couple of reports that rituximab has been used successfully in these people. Otherwise, as Dr. Madhukar said, as Dr. Sharma said, steroids has got a very, very limited role, except in crisis and a couple of situations, other situations. Yes.
If you talk about immunosuppression, probably one of the way which neomercazole acts is depleting that immune-mediated injury of the thyroid. And it was initially when we were students, it was said that block and replace and give it for a longer period of time, and maybe there are chances of the longer the patient takes. So there are a lot of controversy that whether some sort of immunosuppression is going to help or not with thyrotoxic.
Right. Yeah, Mohan, you wanted to?
Yes, sir. Just a point, sir. Amiodarone-induced thyroiditis, that is autoimmune thyroiditis type 2. That is one clear-cut indication where steroids can be used. It's a destructive thyroiditis. So other condition, autoimmune type 1, it's actually antithyroid drugs. That's we can only do by ultrasound or by flow by a doctor that we can help Otherwise, I think steroids have limited role in hyperthyroidism.
Right. So that's a clear message. And yeah, Dr. Sharma, you wanted to say something?
There is very occasionally, not very commonly, patient is having some fear of eye disease when you are giving radioactive iodine. So some of our colleagues are giving radioactive iodine under the cover of, you can say, steroid. So they think that probably radioactive iodine is notorious for precipitating thyroid eye disease. So there's people are using this steroid cover, but not really very effectively. Yeah.
Right. So can we let Dr. Sharma and Dr. Abhay Shahu, if they really must leave, then we will let them go and do other important businesses of the evening.
Thank you.
We can
Thank
continue.
Sir,
Thank you.
sir, I also have a business to attend.
No. First, you have to show yourself. We haven't seen you properly.
Okay, fine.
Anyway, no. You were in the car. I know you're moving somewhere. Yeah, sure. So we will continue with Sushil and Mohan. We shall continue.
So I'm there. Problem.
Okay. Good. So we have still anti-thyroid. So we are still with hyperthyroidism, and the question, maybe Abhay, you can take it. How long should you continue anti-thyroid drugs? And that will also bring in the issue of what are the treatment modalities and how do you choose and all that.
So thank you, sir. So we know there are actually, it will discuss the treatment modalities. We have medical treatment, surgical treatment, and radioiodine therapy. Then once we'll come to the first part is any person coming with thyrotoxicosis, medical treatment is the first to be started. So we have methimazole, we have carbimazole, methimazole. Of course, these are the most commonly used drug. But propyl thyroxine has limited role, specifically during pregnancy we can use. But otherwise, those who are having allergy to methimazole or carbimazole, they can go for propyl thyroxine. Otherwise, majority people are being actually treated with either carbimazole or methimazole. Then comes what is the usual duration. Classical duration is up to 12 to 24 months. Majority people undergo remission by 12 to 24 months. By rule, if you see after 24 months, 30% undergo permanent remission, then 30% having recurrence of the disease, and another 30% become hypothyroid. This is the thing what we classically got. Those who are having recurrence of the disease, they need some other modes, like they have to go for long-term and a medical treatment, or they can go for surgical treatment, or they can go for radioiodine therapies. Coming to the surgical part, if someone is having a huge goiter, already we have with medical treatment, we have made the person T4, T3, T4 normal, TSH might be suppressed. And patient wants a surgery for the cosmetic reason. There is a huge goiter. And we know that those who are having huge goiter or those who are having very high TRAB antibodies, these people are unlikely to be undergo remission with particularly medical treatment. So surgery is an option for them. Those who are having Graves' disease, again with T3, T4 normalization, they can go for radioiodine therapies. For radioiodine now, actually there is two schools of thought. Actually in American, they usually prefer radioiodine therapy, but European, they usually prefer for prolonged antithyroid drugs. But again, if someone is not planning for pregnancy for next 6 months to 1 year, and also someone is actually children, they accept those people, radioiodine is quite safe for each and every person. Even if in the multinodular goiter, surgery is another option. Radioiodine can be given if the goiter size is small. But for toxic adenoma, the best treatment of choice is radioiodine therapies, because we know that the nodule will be ablated and the rest of the gland will remain active, and that will help because the patient will be again euthyroid after this radioiodine therapies. So these are the certain, actually, roughly these are the things classically we follow in the clinical practice.
Right. So what is the scope of continuing antithyroid drugs for 5 years, 10 years? Can we continue?
Yeah. Actually, those people who are having recurrence, we have to go for long-term therapies. Might be 5 years, might be 10 years. Those who are not ready for surgery, those who are not ready for radioiodine therapies, we can continue long-term. We have patients, we are continuing for up to 8 to 9 years with antithyroid drugs, and they are doing well. And they are actually normal. They are very low doses. They are taking low doses. If you stop, there is recurrence. But they're with low doses, they're actually maintaining and they're actually having normal life. There is no problem. We can continue that.
Right. And this is a very often asked question, and endocrinologists can go on discussing this issue over hours. But I would like Dr. Sushil Gupta to take on this question from Dr. Gupta, another Dr. Gupta, as to when to start treatment in patients with subclinical hypothyroidism.
Thanks, Shumanka. Treatment of subclinical hypothyroidism is not mandatory for all the people with mildly elevated TSH. Actually, the definition of subclinical hypothyroidism is if it is upper limit of normal range, but above the upper limit of normal range, and less than 10 microinternations per ml. Not all needs to be THF. There are certain few indications which we need to think of. If you have a goiter, if TPO antibody is positive, if there is a menstrual irregularity, if you are planning for conception in pregnancy, and these are few situations one should really think of starting treatment. Otherwise, the point is why we need not to treat all the people is that the resultant outcome is not very clear. So these are situations one should treat these people in this. If it is TPO antibody negative and person is symptomatic from some, because signs and symptoms of hypothyroidism are very non-specific. So a therapeutic trial can be given for about 3 to 6 months time in these kind of people to see the improvement. Some people do improve, some people do not improve. So the people who improves, actually they can be continued, but the long-term beneficial effect, we don't know ultimate outcome actually. So these are the few indications to treat subclinical hypothyroidism in clinical practice.
Sir, actually, what Sushil sir is telling is an absolute indications. There are actually certain studies, those who are having dyslipidemia with subclinical hypothyroid, they have actually given thyroid replacement and they have found there is improvement in the lipid profile. Of course, this is the individual choice, but there are certain studies in the dyslipidemia with subclinical hypothyroidism, they have given thyroid hormone replacement.
Dr. Abhay, I agree to a certain extent, but it's a hugely controversial area. If you look at Harrison, this is papers coming in 94, American Journal of Medicine. The first key paper we said that it came into the Harrison, then disappeared again. So this is one of the very unusual situations that for dyslipidemia, subclinical hypothyroidism you need to treat, because the decline in the LDL cholesterol with levothyroxine is not more than 5 or 7 milligram per deciliter actually. So this is at the ultimate outcome into the cardiovascular outcome is not very clear actually. That's the basic mandate actually. So I agree with you. Some people may recommend, but universally it's not a really accepted phenomenon actually, because the amount of decline in the LDL and ultimately cardiovascular outcome on a long-term basis is not very clear. If you look at a meta-analysis of subclinical hypothyroid cardiovascular outcome in the elderly age group, as in the younger age group, the beneficial effect, there's a very excellent study from Japan spanning around 20 years actually, in a cohort of around 300 or 400 Japanese people, which showed that as the age increases, if you treat hypothyroidism in these kind of people, there is a subtle decline in the cardiovascular outcome. But the kind of those studies of 20 or 30 years of follow-up are very few, or 2 or 3 studies are there. So it's not really very greatly accepted to treat lipid profile. You need to treat actually. If you see the evolution of this part of it, yes.
Yeah, Abhay also did say that this is not an absolute indication, but could sometimes be used. Yeah.
Sir,
absolutely.
One thing I would like to interject here. I am a bit of a if there is a patient who has got subclinical hypothyroidism and this give, correct the thyroid and lipid level improves, I presume that it is due to that, and I will continue on that. It's not for cardiovascular outcome, but the dyslipidemia part, if it improves on giving it, I will definitely continue. And if it doesn't, so that is my take on that.
Right.
And what Sushil sir was telling, there is again there is a study which has clearly shown more than 70 years giving replacement, that is bad, increases the cardiovascular mortality. Below 70,
that is for
cardiovascular.
For cardiac failure.
It is not for dyslipidemia. It is not for dyslipidemia. It is for cardiovascular outcome.
Absolutely.
I am talking about dyslipidemia.
Actually, the ultimate aim to treat dyslipidemia is to prevent the cardiovascular outcome, actually. So, and that's the basic aim of treatment, actually.
Yes, but these studies, they talk more of cardiac failure rather than possibly a myocardial infarction as an event, as a cardiovascular outcome.
An atrial fibrillation,
so So we are back to pregnancy, first trimester. Mohan, will you take this question? I think it's from Dr. Vishnu Vasudevan. The traditional TSH target is says to be 2.5. So if a hypothyroid lady comes for preconceptional counseling with TSH at 4, do we need to increase the dose to achieve TSH less than 2.5? What would be your advice now today in 2022?
Yes, sir. So there is a debate very recently also about this. So 2.5 to 4, I think Indian there is no evidence, but outside India some evidence was there regarding Assisi et al. And some other articles. Also Negro et al. From USA, that there is a benefit in giving thyroxine in those who have recurrent abortions or on ART or artificial reproductive technique or anxious to conceive, but are all soft indications. But in Indian setup, I think 4 are, because our cutoff, there is a publication by Felix Debar Singh, Dr. Saumik Goswami, Shobodik, they have got Indian data because there is no normative evidence, population specific data level, uniformity is not there. There are some populations for which 7 also 5 or normal is also normal. So there are some unclear indication because of iodine intake and all conditions. But that put aside, I think 4 will be a reasonable value which we all will adopt. I think nearly 4 will be okay, but 2.5 to 4 again depends on the clinical judgment and the expertise of that person. Maybe that's what guidelines also say.
Right.
If you look at, if you look at Dinesh Dhanwal paper, which is about, which shows the upper limit is around 6 microdecision per unit ml per active. 2.5 and 4 is usually controversial area, very soft indications, no resultant outcome. And if you look at 2 studies published in NEJM, actually, which is really, if you look at the guidelines and if you look at those 2 papers in NEJM on subclinical hypothyroidism and treatment effect on maternal and fetal outcome and the IQ levels at the age of 4 years, and where the subclinical hypothyroidism is defined between 2.5 and 19.9 actually, and it showed no difference. I don't know why that kind of study is never quoted actually, but overall 2.5 and 4 we do not treat actually. We do not treat. If it is TPO antibody positive, if it is recurrent abortions, then we treat it. Otherwise, we serially follow them up for gradual prognosis. If there is a substantial rise by the more than 25% of TSH, then we start treatment. Or if it crosses 4, then we start treating those people. So TPO antibody must be done these people. They can be treated if a recurrent abortions or some poor maternal outcome is there in the previous history. Then we need to treat it. We do not. I do not personally treat 2.5 to 4 actually. I do not. I just keep a track, carry TPO antibody, look at gut, and then move forward.
I think that's what most endocrinologists would follow. Right. So we're coming towards the end of this hour's very interesting discussion, and I find that more than 800 of our physicians from across the country have joined in. Hopefully they find it useful. So one, Dr. Monica. So she wants to know, in thyroid storm, the choice of steroid is said to be hydrocort. Can other steroid be given? Is that correct, that choice of steroid is hydrocort only?
So I think dexamethasone. Yeah, I think dexamethasone would be a better choice than hydrocortisone, because actually if you see the peripheral conversion, probably dexamethasone is among the steroids. Dexa has the highest potential of preventing the peripheral conversion. So otherwise, any steroid we can use, but Dexa has little bit over edge in comparison to other steroids. Of course, we have to give
Right.
steroid to every thyroid storm patients.
Right.
Traditionally, we have been using dexamethasone actually, to be very frank. Traditionally, we have been using. There is no head-to-head comparison, hydrocort versus, but T4 to T3 conversion basically effect of glucocorticoids, not specific dexamethasone. High potency, and it is actually life-threatening situation. So you are using high potency glucocorticoids. That's it.
And if there is a element of hypoadrenalism, maybe hydrocort is better. But if you are giving for thyrotoxic crisis, dexamethasone does not induce much of electrolyte imbalance, which a hydrocort will do in the usual doses when we are giving. So it's always a safe bet to give dexamethasone.
So
Because
maybe,
if
I mean, one could use either, but yeah, as Sushil Gupta rightly pointed out, traditionally, actually, dexamethasone has been used more often, but I suppose hydrocortisone should also be effective. Right. And so finally, Dr. Madhukar Rai, only recently T3 has been made available in our country as well. So where would you place it? Where should one use it? Is there a place for use of T3?
definitely, sir. If the patient has got myxedema coma, and I would prefer to have an injectable T3 also if it is available.
Now, with oral, is it only oral available? It's not injectable.
Yeah, if it is, it will be further better because of a predictable pharmacokinetics which we will have in those group of patients. Otherwise, there are
But T3 in myxedema coma has not actually been shown to benefit. Actually, has increased mortality. I mean,
sir,
the evidence.
Yeah, sir, actually, there is a head-to-head trial between T3 and T4, which has shown in the T3 group, initial response is better, initial symptomatic improvement is better, but the cardiovascular mortality is higher in T3 group in comparison to the T4 group. So again, this is the reason why they have gone for a combination of T3, T4, and probably they got a little bit better result in comparison to T3 alone. So here actually this T3, which is orally available, there are studies, those who are having despite of replacement, those who are having still some sort of hypothyroid symptoms, they are feeling discomfort, physical letharginess. There are studies they have actually added T3, but still it's guarded. Actually, there is no definite indication where it can be used. I don't think I have actually gone through any definite specific indications of oral T3.
If you have got a very rare disorder of monoiodinase deficiency, that's one definite indication where you have to give. Otherwise, if a very sick patient, you can transiently give for myxedema coma. Otherwise, if you look at the literature, it doesn't. Theoretically, definitely, it acts immediately, improves immediately, most of the things. But it's one thing which is coming abruptly, always have got some side effects. It's not a smooth transition, and we have to balance the situation. That's one we have to look at.
I think if you talk of in general clinical practice, if you're not talking of, Shubhankar, can you just 30 seconds I would take. We are running out of time. I'm saying. If you're talking clinical practice of primary hypothyroidism and use of T3, there are very, very few select situations when you have a very subtle feature hypothyroidism not resolving with appropriate level of TSH less than 2.5 or so. One can give a fair trial of T3, assuming that might be also giving some improvement. But again, there is a lot of varied experience with the kind of T4 and T3 combinations in this actually. So it is just a hit and trial basis. If the patients improve, you can continue. If it doesn't improve, you can go back to the T4 alone actually. Because treatment with T3 is not cheap. It's pretty costly actually. And the outcome is not great as you look at the quality of life studies actually. It's very mixed picture, which if you look at individual, there's a lot of varied literature. This thing, of course, we have to generate more experience when it has arrived. It's the first time we are going to use it actually. So I have gone to personal experience. Anybody who
Professor,
So one point
Professor.
regarding that, sir. Yeah, one small point regarding that, sir. If the person receives a leonoma or what, a T3, so will it have a effect on the thyroid function levels also? Because interpretation thyroid function, will it also be changed by giving that? I had a doubt on that because because when you give combination of T4 and T3 or so, how will the next function? How will we able to titrate that? How will we do that? That's also one thing which may be doubtful because our assays are also somewhat chemiluminescent assays. So will they affect? Is it free T3? We don't do T3 usually in our lab unless it is a Graves, but T4 at least we do that. So will it affect the thyroid functions in that case? That's also my doubt regarding.
I think we have to go do the TS statistician that TSH actually is we have to give a proportion as a T3 and proportion as a T4 actually, and look at the bottom of TSH which is ultimately remark this thing.
TSH only
we focus on free T3 or free T4 that much. We will look at a TSH level.
TSH only.
Professor Subankar Chaudhary must have a very good experience of using desiccated thyroid because he is from Calcutta, and people, and he's been using thyroid treatment for very long. The desiccated thyroid extract was nothing but a combination of T3 and T4. Sir, are you there? And what is your comment on?
So I mean, that was actually very early in the course of my career, and I think we have evolved beyond desiccated thyroid, and we have now gone on to purified T4 available, and I am by and large happy, satisfied with T4, and there are very few instances, at least at this point of time, that I can think of where I can use T3 long term in management of hypothyroidism, but maybe
Sir,
I was just wondering if you are switching from desiccated thyroid to Eltroxin.
Dr. Madhukar, I have used Proloid when I was doing MD medicine actually with Dr. Hazra. Proloid used to be the drug.
Yeah.
And when levothyroxine Eltroxin was launched actually way back 84, 85, I believe. The people used to take Proloid and then they shifted to levothyroxine. They said we are not as good as we
as good as. That's what I was asking. Because
the problem was Proloid was the standardization. Actually.
Standardization, yeah.
But now if you look at it now, the desiccated thyroid internationally abroad, they are more standardized with LCMS and likewise. But again, the textbook says that they are not recommended. But again, the people who were on Proloid and shift to levothyroxine, they said, "Sir, utna badhiya nahi lag raha jitna pehle lagta tha." So again, because we are not using it, so possible.
So that's why I grabbed this opportunity to ask Professor Subankar Chaudhary because he is senior to us and he knows, he has seen the transition. And probably.
Yeah, I as I said, I don't recollect very well having used the desiccated thyroid on too many of patients. So I won't be able to share my personal experience. Sorry.
Fair enough.
Right. So I think we had wonderful discussion. Yes, Sushil, you were going to say something?
Nothing. I'm talking 83, 85 actually. We were running the diabetes thyroid clinic at with Dr. Hazra actually. So he used to have a lot of patients on Proloid. So that's the reason we had just observed that.
Sure. So I think I have got the latest score with me. Mr. Amit Arora has been updating. So there have been 881 physicians from different parts who have tuned in to listen to learn from Dr. Sushil Gupta, Dr. S.K. Sharma, Dr. Madhukar Rai, Dr. Abhay Sahu, and Dr. Mohan Shenai. So thank to all of you panelists and of course to all of you participants for making this an interesting forum and providing those interesting practical questions to exercise the minds of this great endocrinologists that we have this evening. And I would like to thank the INTAS team overall, and especially the division headed by Mr. Amit Arora and his very efficient team for making this possible and arranging for this dissemination of knowledge. So thank you once again. So it's back to Mr. Jinoy Kuruwalla to provide the finishing touches to this evening's learning program.
Thank you, Doctor. Thanks a lot. So very good evening, doctors. Today again, we could invite a very interesting discussion on the Endocrine Talk Show platform. We could discuss at length on various aspects, and challenging situations revolving around the thyroid disorders and what kind of differential approach can be taken, what kind of differential investigation to be done, and some valuable tips, for all the clinicians attending to take back home. And I'm sure, a lot of clinicians would have come out with some of their doubts during this program, and most of these doubts would have been cleared through this discussion. So on behalf of Intas Pharmaceutical, I am extremely thankful to each of the panelists, especially Dr. Sushil Gupta, Dr. Madhukar Roy, Dr. S.K. Sharma, Dr. Abhay Sahu, Dr. Mohanty Shinoy. Thank you all for your contribution during the session and sharing your valuable clinical insights during the program. We are always indebted to Dr. Shubhankar Chaudhary. Endocrine Talk Show is the brainchild of Dr. Shubhankar Chaudhary, and Doctor has kept always the panelists and the attendees completely hooked on to this program with some of the most interesting discussions. And when we go to the field, we get very interesting sharing of data with a lot of doctors saying that they have been greatly value added through this program. I'm extremely thankful, Doctor, for what we have been able to, do through this program and reach out a lot of doctors and value add them through these sessions. Today, as Doctor was saying, almost 881 doctors have attended the program on a Saturday evening, and I'm extremely thankful on behalf of Intas Pharmaceutical to each one of them. And I'm sure through this program, we will keep on keeping you excited through various topics, which will add value to your clinical practice. Thank you again. Thanks to all. Thank you, Doctor.